So, welcome everybody today to the Basic and Advanced Pharmacologic Management for Obesity and the Medical Management of the Post-Bariatric Patient. I am Nasreen Al-Faris. I am a consultant endocrinologist. I am also a consultant to obesity medicine. I work at the Obesity, Endocrine and Metabolism Center at King Fahd Medical City, and I am also the co-chair of the World Obesity Federation and the GCC in Lebanon, and the chair of the Integrated Health section of IFSO. So my talk today is really targeted toward physicians. Surgeons are more than welcome to attend, and mostly physicians, internal medicine, and family medicine, dietitians, probably, and we'll start there. So I will start with the first poll asking, where are you guys from? Can we launch the first poll, Sarah? No, not this one. You probably did not add the poll. So let us just then minimize this. Please don't answer this poll. There was a poll asking about specialties. So let me then move on to our next slide. This is not functioning. I apologize for that. Okay. I'm going to start with the first case, which is pharmacotherapy for obesity. So our patient is a 20-year-old female who presents for initial obesity medicine evaluation. She is referred to you by her dietitian in your clinic for failure to respond to lifestyle interventions. Her weight history, and it's very important to take a weight history from patients when they present to your clinic. So she reports that she was always a little bit larger than other girls growing up. So it seems that her obesity started as a child, but she did not feel fat, quote unquote, until the last few years of high school when she noticeably put on more weight. So it seems here with our patient that her weight gain started at the age of puberty. So it probably was hormonally mediated. She graduated high school at a weight of 70 kilograms. So she had a BMI of 29. So she actually had pre-obesity at the time. Then during the first 2 years of university, she continued to gain, reaching her highest weight of 89 kilograms with a BMI of 37. So she really gained quite an amount of weight throughout her university years, which is expected. Obesity is a chronic progressive disease, just like diabetes. So once you start that cycle of weight gain, it really continues on. So her family doctor referred her to the dietitian after noticing her weight gain and elevated lipids. And on her annual checkup, per the dietitian's note, she had only self-directed attempts at lifestyle changes, which included cutting down on sweets, walking more. These attempts never yielded any significant sustained results. So they tried, but nothing really worked. She's been working with a dietitian on diet and exercise for the past 6 months, and so far has lost 6 kilograms, bringing her to her current weight of 83 kilograms with a BMI of 34.3, and she denies any increased hunger and reports normal satiety after meals. And it's really important to ask patients about symptom of obesity. So hunger and satiety are really symptoms of obesity that have to be evaluated when we evaluate our patients with obesity. So what happens to our patients? So this is her weight graph. And again, it's really essential for us to make weight graphs for our patients, because when we make weight graphs for our patients, we really see where the story is going. So we can see this patient has started here at one point with the lifestyle intervention and has lost some weight and then reached a plateau. So when you ask her further about her diet, she tells you that her diet recall on presentation to the dietitian was a blueberry muffin and caramel iced coffee for breakfast. For lunch, she used to have a sandwich with fried chicken and mayonnaise and fries and a Diet Coke. For snacks, she used to have, between her classes at the university, Snickers bars, instant coffee with sugar. And for dinner, she just orders out with her university friends. 3 slices of pizza, probably some mozzarella sticks. And then after 10 p.m., while working on her projects and studying, she'd have an energy drink and probably half a bag of pretzels or chips. So this is before seeing her dietitian and before working on the lifestyle intervention. But after her lifestyle intervention, what she comes to see you now, what she's doing now, is for breakfast, she has 1 boiled egg, she has halloumi or feta cheese for breakfast. She has a slice of whole grain toast, green tea without sugar. She has a latte and with 2% milk. She has 3 dates, a handful of almonds for a snack. And then at lunch, she has it at home, tuna, 1/3 cup of whole grain pasta salad and lemon dressing. And for a snack between her classes, she now brings on with her bananas, Activia yogurt. And for dinner, she orders from healthy restaurants, grilled cheese, grilled chicken breast, and hummus, steamed vegetables. And for snacks, 1 cup of fruit salad, 2 cups of homemade popcorn, and 1 can of carbonated water. So it seems that her diet really changed dramatically after working with the dietitian. And the best way to ask about diet, because people tend to forget, is just a 24-hour recall. So you can just ask your patient simply, when did you wake up yesterday? Tell me what you had for the whole day, including breakfast, lunch, snacks, dinner, everything. Just tell me what you had, and that will give you quite a rough idea of what your patients are having. So you asked her more about her physical activity, and per the RD's note, the patient initially presented with a sedentary lifestyle, walking only to and from her classes, about 20 minutes per day. But for the past 4 to 6 months, she's increased her walking considerably, used a Fitbit, which shows an average of 10,000 to 12,000 steps per day. So she has really upped that physical activity. And regarding her sleep, because duration of sleep is very, very important, and circadian rhythm as well, she tells you that she typically sleeps from 12 a.m. to 7 a.m. most days of the week. And some week when there are exams or deadlines, she drops to 4 to 5 hours per day. She usually feels rested. She doesn't give you any history of smoking, nocturnal awakenings, daytime sleepiness, or morning headaches. When you ask her about her stress, she tells you that her student life is very hectic, but she's doing better with time management this year. She describes having a normal college stress related to assignments and her exams. So regarding her circadian rhythm, she tells you that there's no noticeable circadian rhythm disruption. Her diet structure and sleep timings are fairly regular now. Psychological, she's unhappy with her weight. She's very frustrated with the lack of weight loss, although she's really done a lot of effort over the past 6 months with changing her diet, changing her physical activity. She denies any anxiety or depressed mood or anhedonia. She has no history of emotional eating or binge eating when you ask her about both. And her family is really very supportive of her weight loss. Past medical history, dyslipidemia diagnosed 8 months ago by her family doctor. She has not been started on meds yet. And she has GERD for the past 1 year. It's controlled on PPIs, never had surgeries in the past. She's only on the omeprazole for her GERD, and she has known allergies at all. So when you dig further into her family history, there's really no family history of severe obesity in her family. Her father, though, has a history of questionable high cholesterol. She's not really sure, but he's thin and active. Her mother has pre-obesity as well. It's mostly in the femoral and gluteal region, and she has a hypertension as well. Maternal grandmother had a history of type 2 diabetes. She has 1 elder brother with no weight issues. Her two sisters, she has one with the same body shape as her mother, but she doesn't really have obesity. And she has a younger sister which, with age of 15, with weight is normal. So there's really no family history of obesity in this family. It seems that our patient is the only one with obesity now. When you dig into her social history, she doesn't smoke, has never smoked, no alcohol or drug use, and she's a full-time architecture student at a local university, and she lives with her parents. So, physical exam, as I said, her weight is 83, BMI is 34.3, and everything is really within normal. She has more gluteal femoral fat, more than central distribution. She's really following her mother and sister's pattern. You do her lab data, everything seems to be within normal. So micronutrient, TSH, kidney and liver function, electrolytes, CBC, everything else seems really within normal limits. And I've listed here some of her labs, nothing really of concern with her. So the first question is, why is she not losing weight? Is it because she's probably not being completely honest about her diet and needs to work further on reducing her intake? Is she not active enough and needs to add an hour of moderate intensity exercise 5 days per week? She has an elevated adiposity set point due to energy regulatory dysfunction and cannot be completely reversed by lifestyle alone? Does she have insulin resistance that is preventing her weight loss, or is she likely having Cushing's syndrome and needs either 24-hour urine or cortisol for screening, or does she need a dexamethasone suppression test? So I've hadn't added a poll in the first case because I want this case to be a learning curve for you. You will see more polls as we go. So let's think about these. Is she not being completely honest about her diet and needs to work further on reducing her intake? Honestly, people come and tell you the truth. She's been working on herself for the past 6 months. So it's really in her best interest to lose weight. So when people come and tell you in clinic that, this is my diet, I am not eating, please believe them. People do not lie. If you think that people are underestimating what they're eating, sometimes it does happen. The best thing is to tell your patients to start a food diary. But with her following up with a dietitian, it is really unlikely that she doesn't know what she's eating, because this is the point at 6 months after following up with a dietitian that she really knows what she's doing during the day. If she's not active enough and needs to add an hour of moderate intensity exercise 5 days per week. Now, this is a very interesting choice. It's very important to know that exercise really does not lead to weight loss, and it leads to weight loss maintenance. So people that exercise will maintain the weight. Probably they stop exercising, they will gain the weight because they've lost that thing that makes them maintain. But exercise on itself, for most people, does not cause any weight loss. And our patients have been doing very, very well with 10,000 to 12,000 steps per day. So I'm really not going to advise her to do more exercise given her busy schedule and given what she's done. I think she's done more than enough regarding physical activity. So does she has an elevated adiposity set point due to energy regulatory dysfunction that cannot be completely reversed by lifestyle alone? That would be basically the choice that I would choose, that I would pick, because obesity essentially is an elevated fat mass set point or adiposity set point. And you can do so much to change that set point or to try to manipulate it. And it seems that lifestyle has done its job in manipulating our patient's set point. So does she have insulin resistance that is preventing her weight loss? It doesn't seem from her labs at all that she has any type of insulin resistance. And she most likely doesn't have Cushing's syndrome. She doesn't have any other features of Cushing's. And from her physical exam, she really doesn't have anything that points into Cushing's. So as long now that we know that she has an elevated fat mass set point, what should we do? Should we continue with her current lifestyle treatment for another 6 months? Since only 6 months are not at time enough to achieve weight loss goals. Or should we continue with lifestyle treatment, a healthy diet, and more structured exercise and stress reduction strategy? Or should we continue with lifestyle treatment, a healthy diet, but ask her to reduce caloric intake by another 500 kilocalories per day? Or should we continue lifestyle treatment and add anti-obesity pharmacotherapy or refer her to weight loss surgery? So continuing lifestyle treatment for another 6 months is really not helpful. Usually when you start any intervention, it being lifestyle intervention versus pharmacotherapy versus bariatric surgery, you should be seeing results within the first 3 months. If you do not see results within the first 3 months, then whatever intervention that you have given really has not affected the fat mass set point. So choices A and B are not really very helpful. Choice C is completely not a good choice and contraindicated because there is caloric restriction in this choice, and we never recommend for our patients to caloric restrict. The reason is when you do that, you kick your patient into metabolic adaptation and you end up in the long run gaining more weight than you have lost in the first place. So we always advocate types of foods and timing of foods and not calories. Always remember, we eat food and we do not eat calories. How about continuing lifestyle treatment with anti-obesity pharmacotherapy? That is a very, very good choice that I see. I think it's still too early to refer for weight loss surgery. She is class 1 obesity. We can do so much with pharmacotherapy. So if you were to choose one of the choices for her, assuming all of them are available, which one would you consider first? Would you consider metformin, liraglutide? Would you consider phentermine, topiramate, Wellbutrin, naltrexone? So honestly, I probably would consider metformin for her first, just because it is a widely available drug. It's really easy to take. Safety profile is very well known. And in responder, it causes wonderful weight loss. And studies in responders, it causes about 9% of total body weight loss, which is amazing weight loss. Fortunately, she tells you that she wants the injections that she's heard about. And you try to tell her about the injections and how to take them and what the adverse effects are and all of that. You discuss with her options, and she still wants the injections. All the other choices here, phentermine, topiramate, Wellbutrin, naltrexone, they're really all good choices for our patient. If she chooses to do the injections, then perfectly fine with me. So you decide to do that, and you prescribe her the liraglutide subcutaneous daily, starting 0.6 titrated gradually every week to 3 milligrams, taken early in the morning, and you review the risks and benefits of the drug. At 3 months of follow-up, she's very happy. She's been taking the liraglutide. She reports her suppression of her appetite. She reports some nausea, but only been doing slow titration and was able to reach only 1.8 milligram, but has already lost 8 kilograms. Her current weight now is 75 kilograms and having 3 structured meals per day. And through her work with her dietitian is focusing on her protein intake now. It's really important to focus on protein intake because of suppression of ghrelin. You get a lot of suppression of ghrelin, which is the hunger hormone. And that really helps with your patients when undergoing these changes in their lifestyle. She still feels the appetite suppression, but not as strongly as the first month, which is completely okay. Appetite suppression does not equal weight loss. You can get weight loss with anti-obesity medication with no appetite suppression. This is a very important pearl that you really have to remember when you prescribe medications for your patients, because they work in more than one mechanism and not only through appetite suppression. So you decide to continue at the current dose and follow up her again in 3 months. She returns for follow-up. She reports no side effects. Blood pressure is normal. However, she's only lost 2 kilograms over the last 3 months and report that she has no weight loss in the last 1 month. She continues to eat healthy, has also started at the gym twice per week to increase her physical activity. Sleep and stress are unchanged with our patient. Now, this is her new weight graph. So here you start her on the lifestyle intervention. She reaches a plateau. You start on the liraglutide 1.8 milligrams. She goes down and then she goes into another plateau. So what are we going to do now? Would you stop the liraglutide? She's not losing any more weight. Would you start phentermine at 15 milligrams daily? Would you start topiramate, start metformin, or try again to gradually increase her liraglutide dose to reach a dose of 3 milligrams? So what I would do, instead of adding another drug at this time, as long as I have a drug that she's only taking half the dose of, I would just go up on the dose, and then if need be, then I can add another drug later on. And this is what we did. So we decided to increase the dose as she is wary of starting another medication with her initial success with liraglutide. You prescribe her the liraglutide 3 milligrams subcutaneously daily with her dose to increase gradually and early in the morning, and you schedule her to follow up in 3 months. And you continue to follow her every 3 months in the next year. She loses 8 more kilograms before she reaches a plateau, and her final weight is 62 kilograms with a BMI of 25.6. So this is a patient that has luckily responded to one anti-obesity drug. What usually happens is patients will probably not respond to only one drug. They'll require more than one drug. And what I always try to remind everyone of is that when you work with our anti-obesity pharmacotherapy, you have to think about it as if you're working with pharmacotherapy for diabetes, for instance. So if you start a medication for diabetes, metformin, for instance, for someone that has a hemoglobin A1C of 8.5% and their hemoglobin A1C goes down to 7%, you don't stop the metformin because it didn't push it down further. You continue the metformin and add something else to push that hemoglobin A1C to less than 6.5%. So it's very important to think about weight loss medication in the same way. So our patient doesn't seem to need any addition. So she reached her weight. So what do we do now? And this is her weight graph. This is her lifestyle intervention plateau, liraglutide 1.8 plateau, increased to 3 milligrams, and this is her now. So great. So what happens? She disappears for 2 years. And then she comes back. She misses her follow-ups, never reschedules, but when she comes back, she returns to you with a 15 kilogram weight regain. Current weight is 77 kilograms with a BMI of 31.8. So you question her and you say, what happened? You discover that she stopped the liraglutide 8 months ago. She was not experiencing further weight loss, and her family was concerned that she was too young to be on a medication long-term. And this is really a very sad story. So this is her graph, and this is one of our patients. So this is a very, very sad story because patients tend to think that anti-obesity medications are only temporary and to reach their goal weights. And patients tend to think that when they reach their goal weight, they can quote unquote control the weight. Weight is not something to be controlled. If we can control our blood sugars and our blood pressures, then we can control our weights. Anti-obesity medication is for life. It is to be taken indefinitely. So when you start someone on anti-obesity medication, you have to have that conversation with them that they will be taking this medication for life. Because if they tend to stop the medication, what's going to happen is that they are going to gain the weight back, because just like an anti-diabetes medication or an anti-blood pressure, antihypertensive, it's going to happen if you reach your blood pressure goal or if you reach your blood sugar goal. We never stop the anti-diabetics or antihypertensives because we know that when we stop them, our patients' blood pressure and blood sugars are going to go back up. And it's the same thing with anti-obesity medication. So I'm going to shift gears and I'm going to talk about managing surgical patients. Now, surgical patients are very interesting because every time that a post-bariatric surgery patient shows up to one of my colleagues' offices, this is the reaction that I get from them. Everyone really hates to follow up these patients. And I think part of this is because they're less familiar with the anatomy of surgery. A lot of our physicians really do not know the anatomy of surgery. They do not know the difference between a sleeve gastrectomy, Roux-en-Y gastric bypass, one anastomosis gastric bypass, SADIs, all the different surgery that were, the duodenal switches. And it's really very important to familiarize yourself with the anatomy of surgery, because once you do that, you will really start predicting what's going to happen. The other problem that I think that, that is a common problem is there's a lack of a strong understanding in the physiological changes after surgery. Our physicians still don't understand exactly what happens after surgery. What are the hormones that are going up and what are the hormones that are going down? Why are these patients experiencing what they're experiencing when they show up after bariatric surgery? So I'm going to give some 3 common scenarios. I will not be talking today a lot about micronutrient deficiencies because I think this is a topic that, that is easily found if someone would go and just read on the SASMBS or the ASMBS guidelines or so. So it's much easier to do that rather than go through a case and just check. But I'll touch upon some of those stuff. And we are going to have some polls in these cases, I promise. So I'll talk first about post-bariatric surgery hypoglycemia. So Mrs. Smith is a 35-year-old woman. She's 4 years post-laparoscopic Roux-en-Y gastric bypass. She presents to your clinic with a complaint of low blood sugars that started 6 months ago. She states that 1 to 2 hours after taking her meals, she gets episodes of sweating, palpitations, and dizziness. These episodes occurs about 4 times per week. And Mrs. Smith does not have a history of diabetes before her surgery, but she's worried now that she's developing diabetes. And it's very important to mention here that I want you guys to write your questions down because I am going to talk to you right after the cases. We're going to have discussions about the different cases since we have their, so let's talk about what happens to Mrs. Smith. So Mrs. Smith tells you that her mother has type 2 diabetes. She sometimes uses her mother's glucometer to measure her blood sugars when these episodes occur. And she reports reading ranging from 80 to 50 milligrams per deciliters. Excuse me, it seems that I have a technical difficulty. I think everything's fine now. I apologize. So Mrs. Smith tells you that her mother has type 2 diabetes. She sometimes uses her mother's glucometer to measure her blood sugars when these episodes occur. And she reports readings ranging from 80 to 50 milligrams per deciliter. So she's got some low readings from these, from this glucometer readings, but some of them are within normal. So it's kind of an iffy report. I'm not really sure what she has when she shows up with this. She has lost 25% of her total body weight and 70% of her excess body weight over the first 12 months. And she was 100 kilograms preoperatively and reached a nadir weight of 70 kilograms. So she was had a BMI of 39, reached her nadir of 27.7, and now her weight eventually stabilized at 73.5, which is quite normal. So some weight gain after bariatric surgery is expected. She gained the weight that is expected afterwards. Her weight loss is expected. So there's really not much that we're worried about in her case. So you schedule her for a mixed meal test. She develops hypoglycemia after the mixed meal test. Her blood sugar goes down to 45 milligrams per deciliter at 110 minutes. She fulfills Whipple's criteria, which is really symptoms of hypoglycemia, concurrent low blood glucose, and relief of symptoms by carbohydrate ingestion. So what do you do at 110 minutes when all of this happens? You go, okay, so you really have postprandial hypoglycemia, which is very, very important to differentiate from fasting hypoglycemia. And why does this happen? So it's very, very important to understand why this happens. So this is just these are beautiful graphs that show. In the dotted graph line here, you can see the patients who have Roux-en-Y gastric bypass surgery, but do not develop these postprandial hypoglycemia episodes. In the dark here, you will find the patients who have gone Roux-en-Y gastric bypass surgery, but those who actually develop these hypoglycemic episodes, and these are the non-surgical controls. So let's look at this is the first graph here. A shows you the blood sugars. So you can see here someone in a normal control who had not had surgery, after a meal you would have those increases in blood sugars, and then it would just normally go down. Post-bariatric surgery, no matter what, if you have hypoglycemia or not, you will have greater surges in those blood sugars. But the difference between those individuals who actually develop hypoglycemia versus not is the how steep the graph is. So they're steeper, the descent is steeper in those who develop hypoglycemia. And why does this happen? Again, it's important to understand the physiology of why things happen. So if you do not, those patients who undergo Roux-en-Y gastric bypass and do not develop these hypoglycemic episodes, this is what happened to them. Every group has an insulin surge after a meal. Everyone has to have an increased insulin after a meal. This is normal. Non-surgical controls, though, have a smaller insulin surge when compared to those who have had surgery. But those who develop hypoglycemia actually have the greatest insulin surges. And this is probably because they have greater GLP-1 surges. So what happens, you can see barely a GLP-1 bump in people who have not had surgery, a greater GLP-1 bump in people who have had surgery, but it is much, much greater in people who actually have had who actually develop those hypoglycemic episodes. So it seems that the GLP-1 surge is a very big contributor to what happens to patients who undergo metabolic surgery. These graphs actually show Roux-en-Y gastric bypass, but now that most of the surgeries that are done are actually sleeve gastrectomies, you are going to see more and more and more patients with sleeve gastrectomies that have these symptoms of postprandial hypoglycemia. The differences are very similar. The surges are not as much, but they still do develop this. So what are the available options for management of Mrs. Smith? And this is really not a choice. These are really the available options that we have. We actually do nutritional management. We do alpha glucosidase inhibitors such as acarbose. We use CGMs in our center. We use diazoxide, we use octreotide, and sometimes we even use gastrostomy tubes. And what gastrostomy tubes, by inserting the gastrostomy tube, what you do is basically you surpass the GLP-1, the area where the GLP-1 is secreted. So when you go down further down the anatomy of the GI tract, you will avoid that surge of GLP-1, and you end up eliminating those severe postprandial hypoglycemia. So you can see here in all the choices, there is no choice of reversal of surgery. We do not really reverse surgery, and we do not do anything surgical to manage these patients. So these patients are mostly managed medically, and 99% work with nutritional management. So what do we do with nutritional management? We give them complex carbohydrates. We avoid simple carbohydrates. So we do not recommend complete avoidance of carbohydrates. That's not a good idea, just complex. We add protein and healthy fats to meals. That will, you remember that surge that I showed you, that GLP-1 surge and insulin surge, that will slow down that GLP-1 surge, and eventually what's going to happen is that you are going to avoid the hypoglycemic episode. You always manage with a dietitian. Please don't try to do this on your own. And review and adjust the meal plan at each visit based on glycemic patterns. So keep on watching the glycemic patterns and keep on adjusting, and your patients will be fine. So, post-bariatric surgery hypoglycemia. What do you do? What do you see on CGMs? Some of our patients actually do require CGMs, and you know, we're lucky at the center. We have the CGMs. We sometimes give them to some of our patients. It's very important here to notice, and this is one of our patient really important patterns, that you do not see any fasting hypoglycemias in these patients who have post-bariatric surgery hypoglycemia. It's really mostly postprandial. So you can see here our patient takes a meal, has an increase in their blood sugar, and then tends to drop, and then drops about 2 to 4 hours post the meal. They have the glycemic events. They eat again, They eat again, and then what happens, they develop another hypoglycemic episode, and then another hypoglycemic event, and this is how it goes. So this is very important to point out. And actually CGMs are a very, very good tool to use because they really help your patients. They give alarms, they help your patients to understand the pattern of their hypoglycemia, and then what happens with those patients is that they start avoiding the foods that causes these hypoglycemias, and their life just shift into a completely better life. So if you have a patient with hypoglycemia, again, I'm going to use this last schematic, is that please, first thing, if they have symptoms, make sure that they actually have true post-bariatric surgery hypoglycemia, because if their blood sugar recordings are more than 70, so the first step is to give them a glucometer and tell them to go home and just write down the blood sugars when they get these episodes, because if their blood sugars are more than 70 when they get these episodes, then this is unlikely hypoglycemia. This is just dumping syndrome, and dumping syndrome is really a sympathetic effect rather than a true hypoglycemia. Or it can be a cardiovascular disorder that's causing them. They could be having arrhythmias or so that causing them their symptoms. But if they have blood sugars less than 70, then it's really possible hypoglycemia, and then you want to confirm it at the time of symptoms. You want to have a documented blood sugar less than 54, and it has to be relieved by carbohydrates. So it has to be documented, have symptoms, and relieved by carbohydrates, which is Whipple triads. If they have the Whipple triad, then you have to make sure, is it really postprandial? Did it happen 6 months after surgery? That's very, very classic of post-bariatric surgery hypoglycemia. And then you do the nutritional treatment. If it's fasting, started 6 months, less than 6 months after surgery, then it probably is not. Please look for consider other causes. I've had a patient that showed up in my clinic who was treated for post-bariatric surgery hypoglycemia, had developed the hypoglycemia only 3 months after surgery, which is completely atypical of post-bariatric surgery hypoglycemia. It was fasting hypoglycemia. she ended up having a missed insulinoma that wasn't diagnosed initially. So please make sure that you ask and test, and really history taking in these cases is the key. So the third case that I will be presenting is bone health after bariatric surgery, which is a very important topic that's oftenly missed. And we will start with Mrs. Wilson, who is a 52-year-old African-American woman. She has a history of severe obesity with BMI of 51. She status post-laparoscopic Roux-en-Y gastric bypass. She presents for her 2-year post-operative appointment with you. Her post-operative course was really uneventful. She responded well to surgery. She lost 33% of her total body weight loss. This is not excess. 64% of her excess body weight. She reached a nadir of 91 kilograms in 1 year. Nadir is basically the lowest weight you reach after surgery. And she missed her 1 year of post-operative visit. So she's there in your clinic right now. She presents with her new complaints of fatigue and muscle pain. She has worsened over the last 6 months. Her primary care physician stopped her statins a few months ago because he thought it was due to her statins, but the muscle pain persisted. She denies weakness or easy bruising. She takes her multivitamins and B12 supplements daily, but she stopped taking her calcium and vitamin D supplements after 6 months post-operatively because of constipation. So, past medical history, she has hyperlipidemia, GERD, osteoarthritis for her knees and hip, but that has resolved since her surgery. She's on simvastatin, which was stopped by her primary care physician 2 months ago because of the muscle pains. She's on multivitamins and vitamin B12, 1,000. So you can see here from her medications, she's not really taking all the required vitamin post-bariatric surgery, which is very, very common. Our patients get sick and tired of taking their vitamins, and it seems that it is not really very well, the communication, it's not very well communicated to our patients. It's very important to take those vitamins post-bariatric surgery. So in her weight history, she has gradual weight gain as an adult. Her lowest and recent weight was 91 kilograms. 1 year after surgery, she reached a BMI of 35. She gained about 4.5 kilograms over the last year, which is okay, completely expected. She tolerates most of her foods. She's intolerant to lactose. She's not able to take, the milks and the yogurts and the calcium-rich foods. She has adequate protein intake, mostly meat, shellfish, especially mussels and clams. She snacks on nuts. She reports adequate fluid intake, mostly water. But she has increased her black tea intake to 4 cups per day because of fatigue. It's very important to ask about caffeine intake post-bariatric surgery because caffeine tends to reduce the absorption of calcium. So that's a very important thing to ask about. She reduced her activity because of fatigue and pain. She used to walk 45 minutes a day for 3 days a week. She sleeps now 7 hours a night, but wakes up periodically with night sweats. So she denies paresthesias, visual changes, urinary incontinence, fasciculations. Her last period, though, was 12 months, and now she's waking up with night sweats. So she's perimenopausal. She's been suffering from hot flashes for the last 18 months. She's married with 2 children in college. She denies any smoking in the past or alcohol socially. Her blood pressure is normal, heart rate is normal, weight, as I mentioned, is 95. All her other physical exam is really within normal. And this is her weight. So she starts here, she gets her Roux-en-Y gastric bypass, she loses all the weight, and then she gains a little bit of weight. So her surgical history, her surgical weight loss is wonderful, expected and wonderful. Her labs are really all within normal, except her vitamin D, which it comes back at 7. Her calcium is 8 point something, and it's within normal, and her phosphorus is 2.3. So other than this low vitamin D level, everything seems to be normal. So based on this, and I think here I have our first poll. If we can get the poll out, let me see if I can actually do this on my own. I probably can. Sarah, can we have the first poll up? Doesn't seem like I have poll control here. Nope. Okay, so which of the following is the next step in her management? Select all that apply. Do you want to start her on the recommended post-operative vitamin D dose of 1,000 units per day? Do you want to write a prescription for Ergo of 50,000 once weekly for 12 weeks? Do you want to check a parathyroid hormone level or restart calcium supplementation, recommending that she takes calcium carbonate 600 milligrams and increase her dietary consumption of milk and yogurt? So we'll give you about 10 seconds and then we'll check the polls. Oh, now I see the polls. Nice. So can we check the result of the poll? Wonderful. So we have the most saying that we start her on the recommended post-operative dose of 1,000. Some of you says, and then it's kind of split between checking parathyroid hormone levels and starting Ergo at 50,000 and restarting calcium supplementation and increasing her dietary consumption of milk and yogurt. So let's go through those. So for the first one, that was actually a trick answer. The recommended post-operative vitamin D dose is not 1,000 international units a day. It's actually 3,000 international units a day. And it's really, I actually put this on purpose because it seems that this is really missed a lot. And people don't tend to start the 3,000. You can give patients a 3,000 daily for maintenance. This is not for treatment. Or the other thing that you can do is give them 50,000 every other week. So that adds up to 100,000 a month, which will cover their requirement. And again, this is maintenance dose for both bariatric surgery. It doesn't matter what surgery it is, either sleeve gastrectomy, Roux-en-Y gastric bypass, one anastomosis gastric bypass, which is called wrongly mini-gastric bypass, SADIs, whatever the type of surgery is, it is always 3,000 daily. Write a prescription for 50,000 once weekly for 12 weeks. I would do that actually because I'm treating her deficiency. Some patients will require more than weekly. We have some patients on twice a week. We have patients on 3 times a week of 50,000. You give them as much vitamin D as they require to have normal vitamin D levels. Check parathyroid hormones. I completely agree. Parathyroid hormones should have been checked with vitamin D. You cannot check vitamin Ds without parathyroid hormone levels, especially in post-bariatric surgery patients. Restart calcium supplementation. Again, I agree, but it is not, this is a Roux-en-Y gastric bypass patient. You can give them calcium carbonate from now till the sun rises, and it's going to be completely useless. Roux-en-Y gastric bypass takes calcium citrate and not carbonate because they cannot absorb calcium carbonate. So calcium carbonate is given to sleeve gastrectomies who are not on PPIs. If your patient is on PPI, they should be on calcium citrate again. So these are why these are not. So you decide to do that. Oh. Let me see if this actually works because it seems like, okay. So you order a parathyroid hormone. So this is very important. And obviously her parathyroid hormone is elevated because she has severe vitamin D deficiency. And you replete her vitamin D with a prescription of Ergo, 50,000 per week. And you do what else? You give her a lab slip to recheck these levels in 3 to 4 months. And in addition, you recommend that she starts daily cholecalciferol supplementation at 3,000 international units. So this is her daily requirement. Remember, you advise her to start calcium supplementation again in the form of calcium citrate again, and to increase her intake of calcium-rich foods. If you remember in the case, she was a lactose intolerant, so obviously she can't take all the milk, but just other calcium-rich foods that she can take. At 3 months follow-up visit, she reports her generalized pain and fatigue have resolved. She improved respectively. So probably her generalized pain and fatigue were all due to severe vitamin D deficiency. She restarts an exercise routine consisting of walking 20 minutes twice a week. Discomfort from hot flashes continues to interrupt her sleep. She still relies heavily on caffeinated tea to keep her energy levels up during the day. She finishes the weekly vitamin D. She's taking the recommended daily dose of vitamin D and calcium and B12. Her recent labs shows that her vitamin D level is at 33, her PTH went down to 70. So we always recommend to have vitamin D levels at the upper level of normal in post-bariatric surgery patients, to try to suppress their PTHs as much as we can, because high PTH is expected after bariatric surgery, and what happens is that it causes more bone loss than we would like. So let's see if this is another poll. Which of the following strategy, this is not a poll actually, is the most appropriate at this time to manage her balance and risk of fracture? Do you check her 24-hour urinary calcium and increase her calcium supplementation? Do you order dual energy X-ray or a DEXA scan to measure her bone density when she reaches age 65, the recommended screening age for postmenopausal women? So remember, she's not 50 and she's not 65 as of yet. Do you order a spine and hip DEXA scan to measure bone density now, or do you order a QCT or forearm bone density scan at her weight, as her weight is a contraindication for spine and hip DEXA? So it's very important to talk about DEXA scan and bariatric surgery. So one of the rules of thumb is that bariatric surgery is good for everything, basically everything really except for bone. It doesn't really do much for bone. It actually, there's an estimated 12% of bone loss at 5 years after bariatric surgery. Bone turnover markers are increased as early as 10 days after surgery. So patients tend to lose a lot of their bone. The issue with DEXA scans, pre-surgery and post-surgery, is that because your patient has more weight on them pre-surgery, you cannot compare those DEXA scans to their post-DEXA scan, or to their post-surgery DEXA scans, where they have actually lost the weight. So what we generally recommend is, if you have a premenopausal woman, is to do a DEXA scan 2 years after surgery. If you have a postmenopausal woman, then you do it 1 year after surgery, as a rule of thumb, because patients will lose. So you have baselines to compare. QCTs are wonderful. We still don't have them widely used in clinical practice, but they are not really as effective as DEXA scans. So they really give you the microarchitecture of the bone. So they're much more helpful than actually DEXA scans. So you recognize that she may have calcium insufficiency. 24-hour calcium would potentially help diagnosis. However, given her mild hyperparathyroidism, you decide to increase her calcium into supplementation to 1,800 milligrams per day in divided doses. Remember that you can only give so much calcium at one time, because the body will not absorb the calcium. Either the patient has bariatric surgery versus does not have bariatric surgery. And yes, the recommended dose of calcium post-bariatric surgery is actually 1,200 to 1,500 milligrams per day, regardless of their menopausal status. And you can increase your calcium as much as you want, as long as you suppress the PTH. You advise her to reduce her tea consumption, because caffeine, again, reduces absorption of calcium. And you order a DEXA. You're aware of the reduction in bone mineral density after gastric bypass. She's postmenopausal and 2 years post-gastric bypass, and the DEXA actually shows you low bone mineral density in the osteoporotic range at her hip. You start IV zoledronic acid as you're concerned about the risk of ulcer formations with oral bisphosphonate. So really post-bariatric surgery patients, we do not give oral bisphosphonates, always IVs. You can give them bisphosphonates, you can give them denosumab. If they're postmenopausal, you can even give them the monoclonal antibodies. So you have her continue our vitamin D 3,000 per day, which they should be continuing for life. So the take-home points here for bone care, and I don't expect people to be endocrinologists here, but I expect them to catch on these things when they're seeing these post-bariatric patients and send the patient to the endocrinologist to get the required care if and when they cannot do the care. But you really have to be mindful of these important factors, especially that younger and younger women are having bariatric surgery right now, and they're going on for years and years and years, and no one's checking these things. So mechanisms of bone loss after bariatric surgery are really multifactorial, and secondary hyperparathyroidism owing to calcium and vitamin D deficiency, mechanical unloading of the skeleton due to the weight loss are among the most commonly cited causes, but we know that they cannot fully explain what happens after bariatric surgery. They cannot explain, for instance, that increase in bone turnover markers. Why does that happen post-bariatric surgery? And really, as I said, bariatric surgery really adversely affects bone mass and its microarchitecture. It induces early and dramatic increases in biochemical markers of bone turnovers, and I said as early as 10 days. Screening for osteoporosis is recommended in at-risk women. Please don't forget. DEXA for postmenopausal women should be done preoperatively and 1 year postoperatively always. DEXA for premenopausal women should be considered 2 years postoperatively. So please, please, please don't forget to do DEXAs for your premenopausal women after bariatric surgery. Oral bisphosphonates is a no-no after bariatric surgery because of ulcer formations. And you could use, as I said, IV bisphosphonate, teriparatide, denosumab, ramucirumab, and ramucirumab is actually only for postmenopausal women if you need to use treatments for osteoporosis post-bariatric surgery. So I'm going to move on to our last case, and these are additional references for you, which is weight regain and suboptimal weight loss after bariatric surgery. How do we treat these? So weight regain after bariatric surgery. We'll start with Mrs. Klein, who's a 48-year-old woman. She's 3.5 years status post-laparoscopic Roux-en-Y gastric bypass. She returns after 18 months with concern of a 14-kilogram weight gain in the last 6 to 8 months. It's quite a lot of weight gain. When you think about her response to surgery, she lost actually 32% of her total body weight and 70% of her excess body weight over the first 15 months. So she had a great response to surgery. She was 125 kilograms with a BMI of 46 preoperatively and reached a nadir weight of 85.28 with a BMI of 31 kilograms per meter square. Her weight eventually stabilized at 90, which is normal. With some weight regain after bariatric surgery is expected. So she stabilized at 28% total body weight loss, 60% excess with a BMI of 33. Her weight at presentation today is 103 kilograms with a BMI of 38. So she has gained quite a lot after her stabilization. So the most important thing to ask these patients is symptoms of obesity. Symptoms of obesity are hunger, satiety, and cessation. It's very important to ask about these three things and to differentiate between satiety and cessation because I get a lot of questions about that. Satiety is basically when someone eats a meal, how long does it take them? How long does that meal hold them till the next meal? So do you have to eat 2 hours later after your meal? Do you get hungry 2 hours later? Do you get hungry 3 hours later? Or do you not get hungry until 5 or 6 hours? That is satiety. Cessation is a very different thing. And it's a whole different pathway actually. Cessation is individuals who tell you, When I eat, all I need, for instance, is half a sandwich and I'm full. Or someone would tell you that, no, to get full, I need to eat, you know, a full sandwich or 2 sandwiches to get full. If I eat less, then I'm not full. So there's a difference between the two. And again, 2 of them require different treatments. So it's very important that when you ask your patients to differentiate between these and ask about hunger. So when you ask your patient, what does she tell you? She described gradual increase in hunger over the last 6 months. So you can see relapse of the disease happen. So obesity is a chronic relapsing disease, can relapse at any time. So hunger is the first symptoms of relapse. She recalls that after surgery, she would feel full with half a sandwich at lunch and a small piece of chicken with some vegetables at dinner. Although her portion sizes gradually increased over time to a full sandwich at lunch and a bit more meat and vegetables at dinner, her hunger was controlled and she felt satiated for several hours after a meal. However, over the last 6 to 8 months, she has been able to eat larger meals at dinner, similar to her large portion sizes before surgery. So it seems like she has a problem with hunger. She has a problem with cessation. And let's see if she has a problem with satiety. Moreover, she is hungry again within 2 hours after dinner. So she has a problem with satiety as well. So all 3 pathways are affected in our patients. So this is really sad. So other things that you ask about are other microenvironmental factors that may affect her weight regain. So she has a busier schedule, balancing stress owing to a retail business and caring for her 76-year-old mother who was diagnosed with colon cancer. Mrs. Klein often accompanies her to the hospital for doctor's visits in the mornings. She says she no longer has time for breakfast or to plan out her meals as before. She's so busy during the day and she ends up grazing on junk food or ordering takeout for lunch. Most nights when she's hungry after dinner, she snacks on Girl Scout cookies. So she has cookies for dinner. Past medical history, she had vitamin D deficiency post her Roux-en-Y gastric bypass, thiamine deficiency, again post-surgery, vitamin B12 deficiency post-surgery. She has a history of depression and anxiety. She has a history of emotional eating that you actually was treated before surgery by behavioral treatment. She has type 2 diabetes, which is in remission after surgery. She has hypertension, which is in remission after surgery, hyperlipidemia, which is in remission, and obstructive sleep apnea, which is in remission. Great. So she takes her multivitamins. She takes the Flintstones one because they taste nice and they're easy to take. She takes calcium citrate because she has Roux-en-Y gastric bypass, so that's the recommended thing. She takes vitamin D every other week, 50,000, perfect. She takes her recommended vitamins. She takes vitamin B12. She takes her thiamine. She also takes escitalopram, 20 milligrams Q daily for the past 5 years. It's very important to ask about weight-promoting medications. So when someone comes up with weight regain, you have to not only to ask about lifestyle and microenvironment, you have to ask about what they're eating, you have to ask about their physical activity, you have to ask about their sleep, hours of sleep, circadian rhythm disruption, their stress level, and weight-promoting medication. So 6 things that you have to ask these patients. She's also on quetiapine, or Seroquel, 150 milligrams, that was started only 4 months ago. So quetiapine is a really bad weight-promoting medication. I know psychiatrists love it, but we in obesity medicine tend to not like it that much. She's also an Ativan, Q6 hourly PRN. After her Roux-en-Y gastric bypass, she was able to discontinue her metformin, her hydrochlorothiazide, her lisinopril, and her atorvastatin. When you ask about her activity, she currently has no structured activity for the first 2 to 3 years after surgery. She went to the gym regularly 3 days a week. She did 3 minutes of cardio, 40 minutes of weight training. So she was doing very well until 3 years ago. She sleeps about 4 to 5 hours per night, so she really doesn't sleep enough. Optimal sleep hours is about 7 to 8 hours. She has no nocturnal awakenings or snoring. She has no daytime tiredness. She's not fully rested when she wakes up in the morning. She stopped her CPAPs after she got sleep study 1 year after her Roux-en-Y gastric bypass that shows that she had really remission of her OSA. Social history, she's self-employed. She's a retail business owner. She doesn't have any any history of any drugs or tobacco use. And she has a review of system is negative, specifically no nausea, vomiting, heartburn, or abdominal pain. And then when we go into her physical exam, it's all within normal. And she has central adiposity, otherwise it's unremarkable. Her weight is 103 pounds now, or 103 pounds actually kilos. Her BMI is 38, with total body weight loss of 18% and excess body weight loss of 39. All her labs are within normal. So this is her weight graph. So you can see here now in her weight graphs, she's got her Roux-en-Y gastric bypass, reached a nadir weight, and then rebound gain stabilization, which is normal. And then she presents here with the weight regain. That's where she presents to you. So what are her possible causes of weight gain? And since I did not put a poll here, I am open for any participants if people want to start participating and thinking about this case. Since we've had 3 cases to practice, what do you think are possible? You can type this in the chat if you want, and let me know what you think are causes of her weight gain. Any takers? So I've had no activity, I've had junk food, anything else? So it seems that a number of you are blaming the activity and high calorie food. So remember, again, we do not eat calories, we eat food. Calories really don't matter. You can eat 3,000 calories of fruits and vegetables and it's okay. So it's not really high calorie foods that is an issue. Or so let's think deeper. So I agree. So it seems that she's eating more. It seems that she's eating unhealthy. So the types of food that she's not eating healthy. But what is the core cause of that? Why do you think that is happening? Any takers? Why do you think that she is really not doing as much activity, not doing as much of healthy food like she used to do? What's going on in her life right now? So it seems, so I cannot, by the way, I cannot see people that are raising hands on my, I apologize, on my thing, but I can see the chats. I can actually only see the direct chats, I've just noticed. So I'm starting to see the chats. So someone said anxiety. And I've heard depression. So I've heard there's no time. So I agree, all of these, looking after the ill relative. So all of these, so let's, so these are all wonderful answers. So let's look at the 6 components that we talked about. So we talked about food as one component, and this is true. She's not eating healthy, so that's one of the things. The other component that we talked about is physical activity, and I agree with you guys. She's not doing as much physical activity as she used to do. The third component that we talked about is sleep. Nobody mentioned sleep. She's only sleeping 4 to 5 hours a day. If you sleep less than 7 to 8 hours, you will gain weight. She's sleeping 1 to 2 a.m., so she has some sort of circadian rhythm disruption. So that's one thing that that's going on. Most importantly, someone mentioned as well that she's taking weight promoting medication. So that's probably why she's eating the junk food, right? It's the quetiapine probably that's causing her to crave stuff. It's the quetiapine probably that's causing her to eat the junk. So it's really biology that drives our behavior. It's not behavior that drives biology. So that's probably what's happening. The other thing, as you said, she's taking care of an ill relative. So there is this stress. Chronic stress tends to cause weight gain. Acute stress tends to cause weight loss. So she is in chronic stress. She's also managing her own business. That's another cause of stress for our patient. She does have a past history of eating disorder, but it seems that it was treated right before, so it doesn't seem that eating disorder right now is really contributing to her weight gain. So let's move on and see what we did for her. So what is the initial goal of therapy in this patient? And I'm going to put this as a poll. So if we can put this as a poll and see. Sarah, please, if you can put this up. Is it to lose the regained weight as rapidly as possible, since the longer the duration of weight gain, the harder it becomes to lose? Is it to lose 0.5 to 1 kilograms per week until the post-op nadir weight is achieved and nadir is the lowest weight after surgery? Or is it to lose 0.5 to 1 kilograms per week until she reaches the weight she was prior to the regain? Or allow the weight gain to continue initially until weight plateaus on its own, or none of the above? Is the poll up? I cannot see the results of the poll, Sarah, if you have them up. Okay, I can see the results now. So, sadly, no. I can see the results of the previous poll, but not this one. Do you have them, Sarah, or should I move on? Okay, it seems. Okay, somebody said, so I had someone that actually answered me in the chat, since we cannot see the poll. I cannot see the poll, at least. Okay, there we go. The poll seems to be up now. Initial goal of therapy. If you guys can see the poll, I'll leave you another 10 seconds. I think we have time to answer the poll. And I would like to see the results within the 10 seconds. Can we see the results now? Perfect. So 22% of you said lose the regained weight as rapidly as possible, since the longer the duration of weight gain, the harder it becomes to lose. 11% said lose 0.5 to 1 kilogram per week until post-op nadir weight is achieved, or lowest weight. And the highest said lose 0.5 to 1 kilogram per week until she reaches the weight she was prior to the regain. And then there was another 11% says allow the weight gain to continue until the weight plateau on its own. And one said 22% none of the above. I'd be very interested to know what the none of the above wanted to achieve. So I would actually have a goal of 0.5 to 1 kilogram pounds per week. Rapidly as possible is not the answer. So we don't have to lose, really doesn't matter the duration of weight that they have regained the weight on, you still can lose the weight. We have really good medications to do that, so it's fine. And we really don't target nadir weight. It doesn't matter, they may lose to the nadir. Sometimes our patient, we get them lower than nadir weight. It depends on how they respond to the surgery. But I would really be interested to see what the patients, what are the physicians thinking when they're saying none of the above? It'll be very, very interesting to see. So you send her to the bariatric dietitian and behavioral psychologist as well to help with stress management. And if you're lucky to have a behavioral psychologist. and the dietitian will help her with planning her meals. And never on diets, please. If your dietitian is putting your patients on diets, then they're really not help them, because what happens with a diet, remember, is temporary weight loss, and you're looking for long-term weight loss. So you want education of the patient, you want to involve the patient. So the best dietitians are the ones that actually educate the patient how to have a healthier lifestyle, rather than give them a scheduled intervention where they will lose weight on, but then years so later, they'll regain it all back. So she meets with the dietitian every 2 weeks for 3 months, went back to eating 3 structured meals a day and healthy snacks in between. She met with a behavioral psychologist weekly for 6 weeks and improved her sleep hygiene, very important. Stress management techniques. Her work stress lightened up. She called upon her other siblings to help out with her mother's medical issues, so that helps really a lot. She also started brisk walking for an hour 3 times a week, and enrolled in a weekly yoga class. So she did a lot of things. And then this is what happens. So you do that, and then you see that she actually loses a little bit of weight. And then she reaches a plateau, which is expected and okay. And it takes her about 3 months. And as I said, 3 months is always the golden time to evaluate. So now she says that she's still fighting hunger. So she still has symptoms of hunger. So symptoms of obesity are still there. Especially at night, she's a bit frustrated that the weight loss stopped despite her doing all the right things, quote unquote. And this is very, very important, is to really put yourselves into your patient's shoes. They really are trying very, very hard to lose the weight. On physical exam, it's unremarkable. Her weight is 98 kilograms now. BMI is 36. Total body weight loss now is down to 22%. Excess body weight loss to 48%. So you really want to work hard with her and do something else. So this is another poll. If Sarah's with us, can you put in the second poll? Which of the following is the next step now? Would you reassure her that she's doing, thank you, Sarah, doing well, and the rest of the weight will just come off gradually? Just keep doing what you're doing. You're doing great, 2 thumbs up, and that's fine. We don't need to do anything else. Or instruct her to increase her exercise to get more weight gain since she's reached a plateau. Or would you recheck her thyroid function and perform a 24-hour urine cortisol? Maybe it's a hormonal issue that she's gaining the weight. Would you speak with her psychiatrist to discontinue the quetiapine or change it to an alternative medication? Or would you start her on an anti-obesity medication? So another 10 seconds and we will see. What do you guys think? So Sarah, can you put on the results of the poll? Wonderful. So some of you are saying, 14% of you say that we should reassure her that she's doing well and the rest of weight will come off gradually. What I would say is please don't. When your patient has reached a plateau of 3 months, that means they have a new fat mass set point and it's not going to be reset any further. They've done what they can do. So always look for the 3-month period as the golden period. If they've reached it, then you have to give another intervention. 14% say instruct her to increase her exercise. We've talked about exercise. Exercise really does not cause weight loss. It causes weight loss maintenance. So if she's doing great with her exercise, we only really advocate 30 minutes of exercise 6 days a week. 30 minutes don't have to be even back to back. You can do them even 1 minute of exercise, studies have shown is enough. So it's really for weight maintenance, not weight loss. Most of your patients will not respond to exercise. Exercise is very, very important for health, but not a weight loss tool. Recheck her thyroid function and perform a 24-hour urine cortisol. 29% sadly answered this. So mostly this is not a hormonal issue. There is no recommendations to check any thyroid function or cortisol function if you don't have any symptoms or physical exam signs that shows you that this is a hormonal function. People do not gain weight. Take this not only from me as an obesity medicine, but take it from me as an endocrinologist. People do not gain weight because of their thyroid. Weight gain of thyroid is very, very minimal. It's really not a cause of weight gain. And if they had Cushing's, she'd have other things. She'd have disruption in her blood pressure and her blood sugars. So Cushing's is a really nasty disease, and it's really mostly not the problem. Speak with her psychiatrist to discontinue the quetiapine or change to an alternative medication. 14% answered this. Although most of you actually identified this as the problem, yet you are not targeting the problem to fix. And start on anti-obesity medication, another 29%. So actually I would do both. What I would do is I would pick up the phone, talk to her psychiatrist, tell them to stop the quetiapine, and probably tell them to start bupropion instead, because this way I hit two birds with the same stone, where I get them to stop the quetiapine and start an anti-obesity medication and a medication for their obesity, for their depression, which is bupropion. But you can do both. But I would really target quetiapine before doing anything else, unless the psychiatrist says we can't do it. So he spoke with her psychiatrist. He agreed she can have a trial of the low-dose quetiapine. The quetiapine is discontinued. On follow-up in 3 months, her hunger is significantly improved. Her weight decreases initially by 5 pounds, so about 2.5 kilograms in the first month, but no further. Her mood is stable. So he treated her symptoms. She didn't lose a lot of weight, but about 2.5 kilograms extra. You decide to start an anti-obesity medication, and after discussing with her therapist, you decide to start her on topiramate, 25 milligrams daily, and then you increase it to 50 milligrams after 1 month. She responds wonderfully to the topiramate. Her weight is usually, you respond really wonderfully to topiramate from our study. So weight is 87 kilograms, and I'll show you the studies on anti-obesity medications post-bariatric surgery. And her BMI is 32 now. Total body weight loss is down to 30%, excess body weight loss 66%, and this is her new graph. So this is her after her Roux-en-Y gastric bypass. She gains a little bit weight after her nadir. She stabilizes. She goes up and up and up. She presents here. You give her the lifestyle therapy. She stabilizes. You start her on topiramate. She loses weight, and then she reaches a plateau. So this is exactly how you're supposed to manage your patient. So always remember to always continually evaluate patients. Think about multiple causes. It's not usually one cause of weight gain. It's usually multiple causes, and it's usually a solvable cause. If you can identify the offender, then you can really take it out and cause the patient to lose weight. So I'm going to shift gears a little bit now, and we were going to just imagine that Mrs. Klein never really responded well to her initial therapy, and that you actually saw her 3.5 years later after her Roux-en-Y gastric bypass, but she is a surgical failure. She was unable to lose weight after initial 17 kilograms, which is 13% of total body weight loss and 30% of excess body weight loss. So unlike weight regain, which really doesn't have a specific definition in the obesity medicine world, suboptimal weight loss has a very specific definition, and it is weight loss of less than 50% of excess body weight loss. If they do, then that's surgical failure, and that doesn't mean that the surgeon didn't do his job. All the surgeons I know are wonderful and really skilled. It just means that the biology of the patient just doesn't respond to surgery. 15% of patients who undergo surgery will not respond to surgery, and it's never the fault of the patient. And those are the patients that really needs the help the most, because those are the patients that are very stigmatized and really suffer because they've not lost the weight. So she's asymptomatic. She is leading a healthy lifestyle. So she, unlike the first case, she is not doing all the wrong things. She's actually doing all the right things. She's not on any medications that promote weight gain. Her weight is 108 kilograms, BMI is 40, and she's had Roux-en-Y gastric bypass. She comes to you and she says, I want another surgery. What should I do? This is her. That's her graph. So what is in this case, of inadequate weight loss, which we call primary surgical failure rather than secondary. Secondary is weight regain. What should you do? Can we have the poll, please, Sarah? This is our last poll of the day, and then we'll start taking questions on all the cases. So would you order a barium swallow to evaluate for an anatomical issue with a gastric bypass? Would you do a trial of anti-obesity medication? Would you start her on a low-calorie diet? Or would you instruct her to increase her physical activity? 10 seconds, and then we'll be done with this last poll. Okay, Sarah, if you may, can we see the results? So nobody instructed her to increase the activity. Great, she's doing enough activity, and it's a split. 33% will order a barium swallow, 33% will trial anti-obesity medication, and 33% will start her on a low-calorie diet. So as an anti-obesity, as an obesity medicine doctor, I will tell you that low-calorie diets are always the wrong answer. As we said, low-calorie diets will kick in metabolic adaptation. They will cause initial weight loss, and then they will cause rebound weight regain, which is really difficult to treat. They make a more resistant disease, so we never treat patients with low-calorie diets. And that's why we always instruct patients to eat healthy. If they're eating healthy, that is it. Would we do a trial of anti-obesity medication? Always. Would I order a barium swallow to evaluate for anatomical issues of gastric bypass? I would. I would always rule out anatomical issues. Back in the old days when they used to do open gastric bypass, there used to be a GG fistula, so gastric fistula. So the food would actually go into the pouch, and then from the pouch, it would go into the remnant of the stomach, and basically there would be no sense of the surgery. And you can clearly see that on a barium swallow. Nowadays, with the laparoscopic procedures, we no longer see that, but it is worth ruling out. That is really most likely 99% of the time, it is not an anatomical issue. It is a physiological issue. It is the biology of your patients. And what you do is really anti-obesity medication. Do we have data to back us up? We have a lot of data to back us up. And I'm just going to point out to our study. This was the biggest study that was done between us in Mass General and Cornell. So what we did, our group, we started patients on medication for both weight regain and suboptimal weight loss. All patients on our trial, 309 of them, lost 5% or more of total body weight loss. 30% of our patients lost 10% or more, and 15% of our patients lost 15% or more. So, and this has been studied over and over and over again with the anti-obesity medication. The Gravitas trial was not powered to look at weight loss with liraglutide post-bariatric surgery. It was powered to look at diabetes who didn't go into remission. It actually showed that patients who underwent liraglutide again lost weight post-bariatric surgery. But again, 46% of the liraglutide responders lost more than 5%, 4% of the liraglutide responders lost 15% of total body weight loss. And again, because liraglutide is not such a good drug, but still it is very important to look at the importance of anti-obesity medications post-bariatric surgery. So take-home points here is primary surgical failure or an inadequate weight loss after bariatric surgery is predominantly a biologically driven phenomenon. Trials of combination multimodal therapy with anti-obesity medication are often required for our patients. Secondary surgical failure, which is weight regain, is a really complex problem. It is multifactorial in etiology. It is never the fault of the patient. Assessment should determine relative contributional, behavioral, lifestyle, iatrogenic, anatomic, biological causes. Mostly it's iatrogenic, it's mostly our fault. We always start our patients on insulin, sulfonylurea, steroids, antihistamines, beta blockers. All of these will cause weight gain. So really try to find out when the medications were started and who started them. When addressing weight regain, the first goal of treatment is weight stabilization, always. So if your patient is continuing to gain, you give them a medication that will stabilize them and not cause weight loss. That medication actually worked. And a transdisciplinary stepwise approach in treatment is recommended. If you're lucky to have a transdisciplinary team or a multidisciplinary team, then please, please utilize your team. But it may not cause complete reversal of the weight regain, and often more than not, you need weight loss medication or anti-obesity medication to be used. And always remember, anti-obesity medication are for life. They are not medication that are used for a short period of time. These are additional references, and I am going to stop sharing my slides right now and instead start with the questions with all the with everyone to see what we could do. So I am here now, and I have all the chats, all the Q&A on. So please feel free on the 3 cases. And again, to remind you, the 3 cases are the case of pharmacotherapy, just basic pharmacotherapy for obesity. The second case was the hypoglycemia, post-bariatric surgery, and then the bone case, and then the weight regain case. Anyone who wants to raise their hand, ask questions, put it in the chat, you're more than welcome to do so. We have 30 minutes for questions. So yes, Iman. Am I able to unmute? So Iman is raising her hand, but I'm not sure if I'm able to unmute her. Can you unmute yourself, Iman, or is it the host that has muted you? You would like to ask about Saxenda, so liraglutide 3 milligram. Sarah, are we able to unmute our participants? Can you unmute Iman? Is that possible? So Iman, until they figure out how to unmute you, can you type your questions for now until we figure this out? Because it seems like okay. So I have some typed. I'm going to get back to you, Iman. If you can type in your question, I'll be more than happy. Does Saxenda really help? Okay, that's the question. So does Saxenda really help with what exactly? Does Saxenda really help with weight loss, with post-bariatric surgery weight loss? You mean with what exactly? GLP-1 receptors in general, or Saxenda specifically? Can you elaborate on your question? So I have here a question by Naila saying, can bariatric surgery be done twice? Bariatric surgery can be done twice and 3 times and 4 times if you want. The question is, how much does it work? And why do we do reversal of bariatric surgery or revision of bariatric surgery? So bariatric surgery is revised in certain cases. We do revisional bariatric surgery mostly in cases with, let's say, with someone who has a sleeve gastrectomy, who does not have, who ended up having GERD, then we reverse it and we do it, we change it to a wound gastric bypass. If your question is asking, do we do bariatric surgery for weight loss? The answer is mostly no, we do not. Because most of the time, because the fat mass set point, really what the surgery does is really work by resetting your fat mass set point. So it's literally like a computer that went into a reset. So once you reset your computer once, it's really hard to reset it again. So when you do revisional surgery, it has been reported in multiple studies that the only weight loss that you get is about 10 to 15 of total body weight loss. And that is not much of weight loss. This is weight loss you can achieve really through medication. And that's why you will find that a lot of surgeons will shy away from redoing another surgery because you don't get much weight loss after the second surgery. So we do it in very, very limited certain circumstances, but it's not oftenly done. I hope that answers your question, Naila, until we figure out how to unmute you guys. Another question that I'm getting from, I'm going back to Iman, if the endocrine physician prescribes Saxenda, does it really help with a BMI of 31? As I started Saxenda for 2 months, lost about 6 kilograms in around 6 weeks. So what you're trying to say, yes. So if I understand your question is, so liraglutide 3 milligram or Saxenda is FDA approved for weight losses of 27 and above in people with obesity-related complications or comorbidities, or in a BMI of 30 and above with no comorbidities. So you can give it. And the expected weight loss, we do not really evaluate weight loss in kilograms. We evaluate weight loss in percentage. So what we do is we give our patients the medication, and then after you give liraglutide, after you reach the 3 milligram dose, you wait for 3 months, and in the 3 months, the patient should lose 5% of their total body weight loss. So if they were 100 kilograms, they have to go down to 95. If they have reached 95, then that means medication success and you continue on the medication. If not, if they've reached less than 5%, then that's medication failure. We recommend, the follow-up question to that was, do you recommend to continue liraglutide 3 months with hypothyroidism? Hypothyroidism is not a contraindication to the use of liraglutide. Thyroid cancer is not a contraindication to the use of liraglutide. So there is really no contraindication. The only thing that is in the label is medullary thyroid cancer, and it is only on the label because it has been reported in rodents. The reason why it is not reported in humans is that humans do not have GLP-1 receptors in their thyroid, unlike rats and mice who do. So there isn't a single case of GLP-1 of medullary thyroid cancer even in humans. So yes, you do continue anti-obesity medication for life. So I have been asked by Dr. Ahmed, what is the difference between a healthy and a low-calorie diet? You're welcome. A healthy diet is very different than a low-calorie diet. I can put you on 100-calorie packs of M&Ms for, I can tell you to just eat 10 of those packs a day, and that would be 1,000 calories. So that would be a low-calorie diet. If I go down to 8, that would be 800 calories. So that would be a low-calorie diet. A healthy diet is different. So a healthy diet is basically the healthy plate. More than half of the plate should be vegetables and fruits. So 5 serving a day of fruits and vegetables. And then 1/4 of the plate should be carbohydrates. And another 1/4 of the plate should be proteins. Either it is animal protein or proteins from plants. And dairy, and it really doesn't matter how many calories your patients are eating. And this has been studied actually in randomized controlled trials. So Chris Gardner and his group, he had 2 groups that underwent an eating study, and he had one group that ate healthy, which means more fruits and vegetables, more complex carbs, more whole grains. The other group ate ad libitum. And what he did was he followed up the caloric intake and the weight of these individuals for a year. What happened is that the group that actually ate healthy tended to lose weight. The group who ate ad libitum ended up at 1 year to gain weight, although the group who ate healthy ended up taking 3,200 calories per day. The group that was eating ad libitum ended up taking 2,800 calories a day. So even when the group who had eaten ad libitum ate less calories, they still gained weight when compared to the group who ate healthier. So it's really healthy eating rather than low calories. Why do we recommend against a low calorie diet? Because a low calorie diet will end up reducing energy expenditure, increasing your ghrelin, which is your hunger hormone, decreasing your satiety hormones, including GLP-1, GIP, CCK, and amylin. And what's going to happen is it's going to kick on a phenomenon called metabolic adaptation, which increases your weight. It causes you will lose weight eventually, and then it will plateau, and then there'll be an increase of weight. And then what's going to happen, people are not going to reach their original weight. They're going to go up a little bit because the body wants to defend that fat mass set point. And then the patient will go on another low-calorie diet. They'll never reach the first weight that they reach. It's going to be lower. And then they're going to go to that cycle of dieting and going up and going up and going up. And this is what's called metabolic adaptation. They end up having a more resistant disease. So low-caloric diets cause temporary short-term weight loss. They're used in certain cases, but we don't like to use them generally in patients because they are not a treatment for obesity. Okay, do we have other questions on any of the cases? So, Naila again says that a diabetologist said to recommend liraglutide first, but I asked about what metformin. Liraglutide has really moderate weight loss. It's about 6 to 8%. Which is not the best weight loss. It is used in certain patients, so some patients will prefer to use it. Some patients will need to use it because it will give better control of their diabetes. Metformin is a very good drug to start with. When you look at the studies for the metformin responders tend to lose about 9% of their total body weight loss. So it's a really good weight. Exercise is great for weight maintenance, but again, please do not recommend exercise to your patients for weight loss because it demoralizes them when they don't lose weight. Some patients may lose weight on exercise, a few, but most patients will not. And that is why we tell patients about exercise. It's very important for weight maintenance. Diet control, as I say again, it's always about healthy eating. It's always about a sustainable plan rather than a short-term plan. What do you think about having 1 meal per day or using glucophage for losing weight? We always recommend 3 meals a day, structured meals. We just don't want patients to get hungry because when you miss 1 meal, you get hungrier on the next meal and you start craving more stuff. That's why we don't recommend, and then glucophage or metformin for losing weight is always my go-to drug. It is the first drug I recommend, but remember for weight loss, you have to go to higher doses of 1,000 milligrams twice a day to get more weight loss after metformin. And again, like all drugs, try it for 3 months. They have to lose 5% of their total body weight loss. If they don't, that means failure, and then try something else. Someone is asking if there is a supplement to cut carbohydrate cravings. We do not recommend to cut carbohydrates in any way possible. I am told that I can actually unmute people, which is new to me. Let's see if I can do that. Oh, no, no, I'm not the one. Dr. Maisa, I think you can unmute yourself.
Yes, Doctor. Doctor, sorry.
Yes,
The
I can
one
hear
who would
you.
like to ask question, it's free
Can
to
you
raise
speak a little bit
hand, and you
louder?
will
Your
send
voice is a little bit on the
request to unmute.
lower side.
There will be an icon of microphone. They can just mute and unmute it. Like Dr. Naila, Eman, and Dr. Maisa, they are able to talk.
They are able to talk, you're saying?
Yes, Doctor. So they just need to unmute their microphone.
Okay, so if anyone wants to unmute their microphone, I am being told by the control here that you can actually unmute your microphones and ask if you want. So I'm going to continue with the questions. Do anti-obesity medication have similar effects in reducing weight? This is a very good question. So when we talk about efficacy, the answer is no. Anti-obesity medications don't have similar efficacy in reducing weight. They have different efficacies in reducing weight. And so, for instance, now that semaglutide 2.4 has been approved by the FDA a couple of weeks ago, that is the most effective weight loss medication that we have. It causes weight losses up to 17% of total body weight losses, which is very, very effective. But that being said, and I again, this is a workshop, I would have showed a slide showing the different efficacies of drugs. It's very important to put in mind that there is a normal distribution curve of response to any drug. So you'll always have the average responders, and you will have the non-responders and the super responders. And there's no way for you to know where your patient falls into that graph until you actually try the drug. And that is why we try to think about other things when we start anti-obesity medication, when we try about benefits beyond weight loss. So for instance, if your patient has diabetes, then it makes sense for you to start them on metformin or a GLP-1 agonist or an SGLT2. That just makes sense rather than starting something like topiramate or phentermine. If your patient, for instance, comes in and they have migraine headaches, then topiramate, or they have, for instance, binge eating disorder, then topiramate is a very, very good drug for them because it's been shown to work in that population of patients. So efficacy is not the only thing to look at when we look at anti-obesity medication, but it's really each patient is very different. And as a example, for instance, I will use the example of liraglutide because everybody wants to use Saxenda. Saxenda is not a very good weight loss drug. It only causes 6 to 8% of total body weight loss, which is really not great weight loss. Yet it is, you have patients that lose so much more than 6 to 8%, and you have patients that gain weight on it. But when patients lose so much more than 6 to 8%, that doesn't mean that it is the most effective drug there is. And when patients gain weight on it, that doesn't mean that it is the worst drug that is available. We always give the medications and then try to evaluate 3 months after, see if they've lost the 5% of total body weight loss, which is really the minimum weight loss that is required to consider a drug effective. If they have lost that weight, then the drug is effective. If they have not lost that weight, then you need to try something else. If they have lost that weight, but they need to lose more weight, then what you can do, you can either go up on the dose like we did in our case of that drug, or what you can do as well is you can add another drug. So use different drugs with different mechanism of action, you get synergy and you get more weight loss. I hope this answers your question, Ahmed. Any other questions? We have a few minutes left for our Q&A. Any other questions on the hypoglycemia, post-bariatric surgery, or the bone care post-bariatric surgery, supplements post-bariatric surgery?
Dr. Nasreen, we have one question here.
Where can you see it?
Yeah, Dr. Amin Sarhan, what do you think about having 1 meal per day using glucophage tablet for losing weight?
We answered that question about the 1 meal per day and using glucophage. There's actually a question from Dr. Iman mentioning is sleep contraindicated with hiatus hernia repair? It depends. It really depends on the surgery. So the short answer is probably not. It depends on the surgeon. I would always discuss this with the surgeons. Even with internal hernias, some surgeons will do the surgery. Some surgeons will just go on and do their own gastric bypass. Some surgeons will repair the defect and go on and do the surgery. So it really depends. So it's not a hard contraindication. The only contraindication to sleeve gastrectomy is GERD. GERD is a hard contraindication to sleeve gastrectomy.
Doctora, we have Dr. Ahmad Alakwa. Do the anti-obesity medications?
We answered that one as well.
All right, so we accommodate all questions. So
it seems really, because I'm getting some on my private chat. I'm getting something in the Q&A. So I'm guessing that there are no more questions that are coming. Yeah, it doesn't seem like I'm having any questions coming into all my chats.
Yes.
So I think we will end it like 6 minutes ahead of time. Thank you everyone for staying for the long run, the 2 hours. I really appreciate it. And everyone have a great day and have a great week.
Doctora, I think we have Iman Mal Mustafa.
Oh, I answered. There's a sleep contraindication with hiatus hernia repair. We already answered that one. Do you have another question?
Yeah, I think everything is answered.
Yeah, I think everything's covered because I have the 2 chats opened at the same time. So I'm hoping that I didn't miss anything, since I don't have anyone with me today except for me and you. So that's what I'm hoping, is not to miss anyone.
Thank you very much, Dr. Nasreen, for your time and for sharing your valuable insights on how promising it is with pharmaceutical options. I really appreciate it. With regards to certificates, someone asked a question about the certificates. They will be sent in the upcoming days, inshallah, certificates of attendance. Thank you.
Thank you so much. Take care. Take care. Take care. Take care. Take care.